You go.
Good afternoon. Happy noon to everybody, and thank you for joining us at this on this MedChi lunch webinar. I'm glad to see so many folks join us today, and I just want to remind you that we are very excited to have you with us because MedChi's mission is to serve as the resource and advocate, the foremost resource and advocate for Maryland physicians, their patients, and public health. And so your attendance, your participation is truly valued. We are really excited. I am personally really excited to have two very special guests who are no stranger to those who follow MedChi. We have an exciting program. It's an update on AHEAD, the total cost of care program that's evolving in Maryland. And our two experts, I'm Eric Wargotz, the president of MedChi, and we have our two experts with us today. Let me introduce you to them. Dr. Ben Lowentritt, he's a past president of MedChi for the year 23-24. He is the chairman of our Looking Ahead committee. He's completely up to date on this topic. He lives and breathes it, and he is a practicing urologist in Maryland. Our additional expert guest speaker is Mr. Gene Ransom, CEO of MedChi. He has been working on the policy as well as the practical aspects of AHEAD since its inception. He has been incredibly involved with the political arena regarding AHEAD and has helped advance most of our interests that we've had success with in the AHEAD model. Why don't we kick it off, gentlemen? Gene, can you give us a little overview on the history of the waiver?
Sure, that's a good place to start. And thank you, Dr. Wargotz, for having us here today. And I thank all the members of MedChi for being here. So essentially, and Dr. Wargotz is being modest about his knowledge of the program as well. And that's why he referred to it as the waiver, because the AHEAD program is actually a continuation of the Maryland Medicare waiver that we've had since 1977. So Maryland is this unique state where hospitals are paid differently from any other state in the union. Essentially, since 1977, we've had special permission to pay for Medicare differently from everyone else. And in fact, since 1977, Maryland has had rate setting, and essentially an entity called the Health Services Cost Review Commission, the HSCRC, has been determining what hospitals get paid. So very early on, with regards to rate setting, what happened was the HSCRC in the state said all payers will have their rate set by this commission, the state commission. They originally set the unit rates, and they would put a cap on the unit rate that a hospital would be able to charge. That meant that the HSCRC would say, hey, you get paid X or Y or Z for a DRG or for whatever is being done in the hospital. And the HSCRC would have to stay below a certain unit rate in order to be successful under the waiver. And over time, in the 70s, we kind of moved towards a charge per case rate, which again still is a volume-based rate, right? You're still getting paid per charge. And again, every payer was setting what hospitals got paid. Physicians have always been excluded. Physicians have always been on a volume-based basis. And as time went on, we've managed to adjust. Interestingly, rate setting was all the rage in the 70s, and multiple states tried to do this for hospital payments, but it didn't work out for most of them. And the last state to have any kind of rate setting commission like we still have in Maryland today was actually New Jersey. And that was a long time ago. I mean, we're talking 30 years, 40 years ago, it went away. But we have continued to adapt in the state of Maryland to allow this Medicare waiver to continue. Essentially, in more recent years, starting around 2010, really starting a little before then, we started in the rural areas with something called total patient revenue. We started moving to global episodes and global budgets. And right now, the rate setting is not set on a per unit basis, but each hospital is given a global budget. And that has really been the case for the last 10 years in Maryland. So we've gone through this process where over time we've made adjustments working with CMMI, and there have been various iterations as to how hospitals have been paid. But the difference is, unlike a physician practice, and this practice would be one that, even if it was owned by a hospital, where they have to negotiate their contracts with payers, the hospitals get a charge or a amount that they're getting from a rate setting commission for all their payments, private payers, Medicaid, Medicare. So prior to 2014, as I explained, the payments were done on a per unit basis, and you had a volume basis, and the hospitals would know what they were getting paid. And again, more recently, we were on global budgets. So when the model shifted in its most recent iteration to these global budgets, it really changed things actually massively for us. What happened was it went from a situation where hospitals, even though what they were getting paid was set by a rate setting commission, and the state of Maryland had rate setting commission, the hospitals were still volume driven. Economically, they were incentivized. The more they did, the more they got paid. There was just a cap or a number on the unit rate that was set by the government. It wasn't negotiated with the private payers, and that meant the hospitals were very aligned with the physicians, right? So that's the way it used to be. But when we shifted to where the hospitals had a global budget, which considered all the services they were providing at that hospital with a contract, then we have a little bit of tension. And that's what we've been living under lately, where the physicians are still in a volume basis, where they negotiate with payers in air quotes, or they take whatever Medicare and Medicaid gives them on a national level. And then the hospitals have a global budget. And that has created the big change that occurred. And what happened is these agreements are essentially signed for 5 or 10 year periods, and around 2026, it was supposed to be renewed. Originally, that was the plan. But for various reasons, it ended up being renewed sooner than it was. And we'll talk about that in a second. But the other thing is because of this economic shift that occurred, there started being tensions, and MedChi started getting more involved and having more problems with the model. So that kind of brings us up to 2023, Dr. Wargotz. Is that good enough?
Very good. Thank you, counselor. And I especially wanted to call him counselor because I want to remind everyone that, we listen to our physician colleagues, our physicians very carefully for their particular jargon and what they say, because we know what we're talking about. We use very precise language. Well, some of you may not be aware that our CEO, Mr. Ransom, is an attorney, a member of the State Bar Association. So when he speaks in regulatory terms, he speaks with precision and accuracy. So I just want to emphasize that as well. Dr. Lowentritt, so as you're aware, a number of members have had concerns about some of the issues around the waiver, HSCRC, and the rate setting. Can you tell everyone here today what we're doing, what MedChi is doing? You've been very active in this area.
Yeah, thank you so much, Dr. Wargotz, and I really appreciate the opportunity to talk to you all. I really like the idea of keeping this in historical perspective because it's very easy to just look at where we are now and assume that, that's all that's relevant. But as what Gene was saying, we had seen a lot. We had seen a lot of
25 years old, 26 years old. It's like,
Can we put everyone on
sorry.
mute? Thank you.
Sorry about that. So we'd seen a lot of changes in the last 10 years, really starting around 2013 was when the global budgets were shifting. But this is all in the environment of what we've seen over the last now almost 30 years in healthcare, where physician reimbursement has been basically flat and really down to inflation over the last 25 to 30 years. So a lot of other things were happening that were driving stress in the system. And Maryland always had this different kind of approach. And, some of the things were, there were national advanced payment models from, that would have made people eligible for different MIPS modeling in the early years that weren't available in Maryland because the waiver exempted us, because anything that in theory touched the hospitals could mess up the waiver calculation, the calculations that went into rate setting, and that would, that meant we couldn't be a part of it. And there was also the reality that you look at Maryland, really, well known for our medical excellence, but 48 out of 50 historically in, physician payment. You look at what happens with ER wait times, and there are a lot of things that, if you look closely, kind of point towards issues with that may be issues with the waiver. And I think, we all kind of felt like, okay, the setup, the incentives are set up in a way that we're seeing these results naturally come out of how the hospitals are adjusting to what the state has put in front of them. Um, I think it's really important to say that the reason that we went to a global budget system was not because the hospitals were looking to see a change. There was a trigger that basically said if the average cost increase for healthcare was increasing above the national average for more than, I think it was like 2 out of 3 years. If it was that it would trigger an automatic renegotiation, and effectively the option was either the model goes away or or we have to come up with something new. And fundamental to this whole thing, and I don't believe Gene mentioned this, but fundamental to why this is relevant is that the federal government funds this historically to the tune of, say, $4 billion, right? That's basically going in through the HSCRC's process largely to the hospitals. And we'll talk about some successes that have been happening over the course of the last 10 years, where some of that has been used to fund other models that we've created in Maryland. But largely, there's this big bolus of money that's essentially standing up this waiver. Now, with the total cost of care model shifting, with the goal of saving some money to Medicare and to the overall total cost of care in Maryland. But it's this weird kind of give take where there's a lot of money coming into the system as a pretty much a straight subsidy to stand up the hospitals to do this. So in 2023, we knew that by the end of 2024, or really by the end of 2025, as Gene said, that we were believing we were going to be negotiating the next iteration of the waiver. And we heard from a lot of doctors that it was time for us to stand up and make some comment on this, because it increasingly was impacting how our community docs were working in our regular practice. So we formed the Looking Ahead Committee, right? And the thing that we spent most of 24 doing, with the thought that we would be negotiating through 2025, was create our 3 one-pagers. And I don't know if we can go back to those, because I was talking over them, but I don't know if people were able to see them. And this framework was based off of what at the time the HSCRC had set up as their feedback committees, was a healthcare transformation, population health, and then a primary care focused subcommittee. And this was how we organized our thoughts. And we had a lot of feedback. Hopefully a number of you contributed. I see a number of the names that are on here today. And obviously these are people that are very interested. There are a number of people that are very interested and passionate about different aspects of this. And I'd say that we focused on a few core issues within these. And a big one was preserving some of the wins that we had been able to get, most notably with the MD-PCP program, in which we were looking to strengthen, and the EQIP program, or the Episode Quality Improvement Program, which had started to see some real success and has continued to in the last couple of years as well. In addition, we were looking for transparency. There was a lot that, as doctors, wasn't visible to us about how the calculations were being made, how any adjustments were being made, and frankly, then accountability, so that if hospitals were shifting volumes or were, lagging on technology or effectively restricting access for specialized care and different levels of care, that there would be some accountability to that. And part of that was the idea that, parallel to all of this was a big drive towards more and more care being given outside of hospitals. So the concept here was that the money should start to follow the patients. Ironically, the hospitals were continuing to get paid for work that effectively they were also building into their outpatient centers, right? So all of this is in the background of what we know has been happening, where you've seen most of our doctors now in the state working for systems and other entities. So you have effectively some of that subsidy is going towards consolidation of physician practices under hospitals, which then kind of drives people back through this system of the hospitals are maintaining, a certain level of volume just to keep their global budget, but also kind of doubling down in the community and effectively competing with the non-hospital physicians. So you have a lot of tension in the model, I think is the right way to put it. And we were looking to get some degree of change to show appreciation for that, so that we could make sure that we really were achieving the goals that was laid out without harming healthcare for our patients and for our docs. So we had this great plan, and we had put a lot of thought of it, and we were getting a lot of good feedback, actually. But then we came to the end of 2024, and when the federal election was looking like it might go in a certain direction, there was a little bit of urgency to try to extend extend into this AHEAD program, which was an initiative that had been launched by the federal government to try again for some new models, state by state models, and was largely actually built on the total cost of care model from Maryland. That there was an accelerated effort to get that signed really late October of 2024, right before the election. That then got disrupted, and I guess I'll probably leave that to Gene to talk a little bit more about what's happened in the last year. But that's sort of where we were historically, and why we were spending a lot of time on this is because there are a number of issues that our doctors have with the current program.
Thank you, Dr. Lowentritt. Really appreciate that really concise synopsis of very complex issues that AHEAD is tasked with addressing, and our history of involvement in that. Mr. Ransom, so most of us are aware that Governor Moore signed the AHEAD agreement quickly, and why was it done so quickly and a little out of cycle? And where are the hospitals right now in terms of their signing on to this?
Yeah, so essentially, the hospitals, the state of Maryland has signed. Well, why don't we back up? I'll back up a
Sure.
little bit. The hospitals are signing participation agreements as we speak. Just like physicians right now, today was the initial deadline. I think they've extended it for the EQIP participation agreements. So they're working on doing that for the new amended AHEAD agreement. But Dr. Lowentritt did a really good job talking about that 23 period where we were talking about setting MedChi's priorities, which we did. The other thing that was going on is MedChi was testifying regularly about concerns we had on the total cost of care agreement and how to improve it. And you see there the former president of Montgomery County Medical Society, Dr. Berger, and former president, Dr. Radising, testifying at the HSCRC. As Ben and you both referred, Governor Moore did sign the new AHEAD agreement, which is the new Medicare waiver, earlier than was originally expected with the Biden administration the week before the election. And that meant that a lot of details were left to be worked out, and a lot of the things that we were hoping to either have adjusted or addressed or changed didn't happen. And what did happen was we kept the Medicare waiver. And I think Dr. Lowentritt explained that there were 4 billion reasons why that was a priority, because obviously if that money were to come out of the system, it could put a lot of pressure on the system. It would be very hard to keep some of the rural hospitals and underserved area hospitals open, and it would just be a significant amount of lost revenue to the state. The other thing is that the current rate setting system, HSCRC structure, is used to subsidize the Medicaid budget for the state. So there were a lot of reasons why this was going to get done and why Governor Moore rushed to get it done. But then, of course, we did have the election the week later, and the new administration had a very new view on how they thought this should work, and essentially said, "Yeah, you signed an agreement. We understand that, but we're not going to move forward with that, and we'll blow the whole thing up if you don't negotiate." And essentially, the state and the feds had a very different view with the new administration on the way they wanted things to go. So the Center for Medicare Innovation said under the Trump administration said, we don't believe in rate setting. We don't want rate setting. There should be no rate setting. We want control of the global budgets. No Maryland CRP programs, which is care redesign programs. Those are the programs like the Episode Quality Improvement Program, like the Maryland Primary Care programs that we have specific to Maryland. They wanted everything to be national models, and they wanted total control. So the Trump administration said, we don't like what the Biden administration did. We don't want the state to have the right to control things. We want the federal government to have control of everything. So they wanted a strong federal control, where the Biden administration priorly gave a lot of that authority to the state HSCRC and to the state administration. And Maryland said, well, we would like the rate setting, the control of global budgets, the local, the ability to develop and build out local care redesign programs, and shared control. So we had a bit of a tension. And immediately, starting in January, when the Trump folks took office, there began to be discussions about how things were going to work. And Dr. Lowentritt and I, because obviously he was president at the time, and he chairs the Looking Ahead Committee at MedChi, we were in lots and lots of meetings around it. And there were multiple committees, coordinating counselors. There's the Head Technical Advisory Committee that continues to work. The new health secretary, who had worked for CMS under the Biden administration, she was very, very obviously involved in these negotiations. And literally, for the first half of 2025, there were regular weekly meetings, and there remain weekly meetings with 3 or 4 different committees that MedChi is represented on, that is kind of negotiating through things. Early in 25, CMS kind of said, we want to make it clear the total cost of care is going away. We're not going back. So they actually repealed the ability to even have a total cost of care. Now, that's not the end of the world, obviously, and nobody really freaked out, because we were already in an agreement with the federal government, albeit a different president, but the federal government to do ahead. So we had an agreement, and that was not going to continue anyway, and it made sense. But it did cause nervousness, and negotiations continued on a term sheet. The term sheet between the state and the federal government was agreed to in the very late summer, and then literally several weeks ago, there was an amendment between the Trump administration and the state administration that ended up with a new model. So I'll turn it back to you, Dr. Wargotz.
Certainly. Thank you, Mr. Ransom. So, Dr. Lowentritt, you, Dr. Radising, myself, and Mr. Ransom were all involved with the Total Cost of Care Work Group, which meets monthly. That's just one of many groups and meetings which involve AHEAD. And I wonder if you could just let us know, speak to the group about how Mr. Crom came to AHEAD, and then MedChi went, and yourself went to visit with Abe, had a conversation with Abe's son over at CMMI. Can you talk a little about the process and how we've been working on this complex issue all along, as well as the work group?
Yeah, it's very interesting, because I think one of the things that our process that I had laid out before, I think we really firmly recognized a weakness in the existing system, is that the HSCRC was always envisioned as a rate setting authority, not a regulatory authority. And the state, and for people that don't understand it, the framework of this has always been between the state executive, the governor's office, and the Department of Health, and the federal government, and CMS and HHS. So, there's not a lot of expertise, or frankly, a lot of input from the General Assembly, on this. That's just not something they've been in part of. So this has always been a very much a two-part conversation, and I would say the hospitals as the primary interest, group of this have had their say through the state and with the state and things like that. So I do think that a lot of the effort that we had done through 2024, both to educate ourselves, and then to start to talk to our, the key parties in this in the state, and led us to be a voice that was able to be heard during this time. And Gene just laid it out that there was this time frame between the new administration coming in and frankly the end of the summer, where the state was saying something very different from the federal government, and that actually created some ability of us to start talking to people. Not that we were undermining any effort, because we really weren't part of the state's effort, although we were talking to them regularly. But it created this ability for us to kind of be in a way seen as a partner for trying to find a solution, because we didn't have such a dug in stance on this overall, and we were frankly looking for some change, maybe not as disruptive as one group might want to be, but certainly not just status quo. And so we've had our regular discussions with the AHEAD committee, and we were able to bring in a lot of the key actors in this, including Director Crum, who heads the HSCRC, and other members from the state and from the Department of Health. But also, Gene and I were able to get an audience with the head of CMMI, Abe Sutton. And this is where I think we started to learn a lot about what the Trump administration's goal for any state models like this for AHEAD was, because it's interesting. They didn't just, scrap AHEAD. I'll be honest, I don't remember what AHEAD stands for anymore, because they certainly changed some of the letters in here, from what it initially was for. But they did say that they want to look for this for some degree of innovation in the Medicare system. And when we went to CMMI, it was very interesting to sit down and talk with them. There were certain things I think they weren't as aware of. I think we actually got a lot of momentum for keeping the EQIP program out of that meeting that we had. But in addition, we learned that their plan really is to look towards this sort of statewide kind of ACO, different attribution model approach. And certainly from the beginning, the federal government said no more to this rate setting concept overall. But through these discussions, I think we were able to kind of help educate, frankly, the CMMI folks on some of the nuances that are in the Maryland system, and with doing that, maybe influence keeping some of those. So I think this actually shows how our we talk about, you just need to show up, you need to be engaged. This was not our typical let's go down to Annapolis and meet with the folks down there kind of approach. These were different people and required different levels of engagement. But I think we were putting in the hard work doing that, not even knowing all the time who was going to be that actor that we were going to meet with in the future. But it really did start to pay off, and I do think we've gotten a little bit of small wins in this very complex big picture project.
Yeah, that's pretty interesting, Dr. Lowentritt. And working with the appointees at the federal level is not an easy appointment to get on the schedule. And we also, are fortunate that we work with a variety of federal representatives, both in the Senate and in Congress. And we happen to have a physician who's part of our congressional delegation, Congressman Dr. Harris. And I think you would both agree, based on our knowledge of his involvement, that he's been also an advocate and very helpful with this, getting to where we are with AHEAD. We don't have everything we want, but we certainly have things that we desired as a medical society for our members and the public, and he has been very helpful. I think you would agree. The state and feds have agreed to change the model, segueing from that. in a term sheet this summer, and it was more recently that the amendments were signed. Uh, could one of you, maybe Mr. Ransom, could you tell us what the difference is?
Yeah, so and actually, I'll start by answering Ben's comment about the name because originally ahead, and I think it really helps you understand the changes to the term sheet in a way. Originally, under the Biden administration, it was called the Advancing All Payer Health Equity Approaches and Development. That was what it had stood for. And then under the Trump administration, they officially, CMS, renamed the model Achieving Healthcare Efficiency Through Accountable Design. And you'll notice that equity was switched to efficiency, and the all payer part, that rate setting part, disappeared. And that kind of tells you where they were going with regards to changes. So just to try to explain it in very much layman's terms, for the next 2 years, the model will essentially run exactly as it has. It'll look just like the total cost of care did. Everything will be the same. There's no changes. So that's the first thing that's important to understand. We'll be essentially on the state setting all the rates for everything, total cost of care for 2026 and 2027. And 2027, we go to actually a split rate setting authority, which creates some complexities. And maybe we could talk about this in a question and answer part. But Medicare global budgets will be set by CMMI. And the AHEAD Technical Advisory Committee is now working through methodologies with the hospitals and other stakeholders on how that's going to work for Medicare. The state HSCRC will remain responsible for global budgets for the other insurers. So we are going from one complicated process that's hard to understand to two complicated processes that are hard to understand, and they're going to be split up for the hospital payments. The other big change is hospitals are now required to sign direct participation agreements with CMMI. Prior, under the old system, the agreements would be with the HSCRC. This is a big deal because obviously it's a major change in how things work. Now, the hospitals were very effective in getting language in there that allows them to reconsider their position at the end of 27 when we come off of the total cost of care. And I think that's another issue that we kind of need to flag for future discussion. I think it also answers the rest of Dr. Wargotz's question from earlier. And right now, my understanding is about 25 to 33% of the hospitals have signed them, and they're on target to sign the agreements because essentially for the next 2 years, they're agreeing to do what they've been doing. With regards to care redesign programs, a lot of the care redesign programs will end, and we are going to move to a lot of the national models. However, the EQIP program was kept. And actually, this was one issue where Dr. Harris actually contacted Theo Merkel directly in the White House about it for us at our request to Dr. Wargotz's point. It was very helpful. We ended up saving EQIP. So rather than EQIP going away, which was what the Trump administration originally asked for, they said after really, I think, the meetings that we had with the CMMI staff, the direct meeting that Dr. Lowentritt and I had with Abe Sutton, Dr. Harris's help, other help, we were able to save it. So that's going to stay in perpetuity as long as the model's in place in Maryland. The other thing, interestingly, is not only did they go from we're going to eliminate it to you can keep it in perpetuity, they've also said they're considering allowing other ahead states to do EQIP as well. So that seemed to have been a very much big success as far as convincing them that this is a good idea and it works well. And we could talk a little bit about that in a second, I'm sure. On the primary care side, we were successful in keeping strong primary care investment targets. The investment targets that were in the Biden agreement were kept. They are much higher than what was in the total cost of care agreement before. So that's a positive for primary care. The problem is that the Maryland primary care program, where a lot of that investment would go through, is currently scheduled to end with a study in 2028. In those list of one-pagers, we asked for a couple things on the MedChi side, including open enrollment, the possibility of continuing MDPCP. There is language in the amendment that allows for both of those, and MedChi continues in conversations about possibly working on getting more for primary care.
Well,
the agreement, those are the big high-level items in the new agreement and where we are with regards to the change. Go
very
ahead, Dr.
good.
Wargotz.
Yeah, no, it's great. That's really good information to have. And I'd like Dr. Lowentritt and Mr. Ransom, I'd like you to elaborate a little more on the EQIP program in a minute, and then maybe Mr. Ransom on the primary care programs. But before we get there, let me just recap a couple of really important points, because as I'm making my rounds around the state, as I know the two of you are, I'm getting a bit of questions about the HSCRC. Will it exist? And I know you answered that. I just want to emphasize it, that it will exist. It doesn't go away if rate setting for Medicare goes away in the state. HSCRC is still responsible for the private insurers setting the rate setting there. Number two, it's really a high praise and compliment to Mr. Ransom and the presidents before me, Drs. Lowentritt and Radising, that this EQUIP program has been such a success. And of course, all of you who see the value in it and participate in it, and those who don't, please inquire about it online or in person with any one of us, because it is a great program. It'll certainly bring in a few extra dollars, perhaps save you time and headache. So let's move on to maybe Dr. Lowentritt. Tell us about the EQUIP program. One thing I get a lot around is physicians now saying to me, okay, we hear a lot about the effect of a head on the hospital payment system. Bring it home to the physicians. Tell us, where do we benefit? Where might we get hurt? Where do we stay neutral? And I think the EQUIP program is a great place to start. What do you think, Dr. Lowentritt?
Yeah, once again, just a little bit of the history here, right, was that when we were trying to nibble around the edges, for the last 10 to 12 years in effectively trying to say, listen, you can't continue this system that's completely geared on the hospitals when there's so much. People have been trying for the last, 20 years, all types of different innovations and episode, and different payment models and things. And we were really kind of had our hands tied. And there were little projects like there's a hospital-based, kind of practice episode, savings model. But the challenge is that once again, it was hard to show savings in a state where they're not willing to take money away from the hospital encounters in a way. So we had to create some different ways to measure it. Now, MDPCP, or the primary care program, was another effort focused on primary care, to appreciate the work that's required to deliver the care and to compensate people for going above and beyond kind of the traditional face-to-face medical interactions that are so necessary, the things that are so necessary to do, and usually often in primary care. And it's been a really big success for doctors that are participating in it. The piece that EQUIP really solved for was that it enabled sort of the outpatient and specialist, will say, although you'll see we're developing it across all specialties, specialists to also have an option, even if they weren't based in a hospital or employed by a hospital. The big allowance that we had to get in this is really two things. Is number one, previously a lot of the models you had to be associated with a hospital, and effectively it had to go through the hospital to sign on. And EQUIP was able to create a structure where we're partnered with University of Maryland as sort of the sponsor in the system, but they really have allowed the EQUIP to be, I won't say independently, but EQUIP to be run by this separate group. And we've been very fortunate that Gene Ransom has really headed up this, and MedChi has had a huge input into the creation of the EQUIP models overall. And effectively, these are, you'll hear bundled care or bundles, you'll hear episodes called different things. But it's a form of value-based care where if you look at an entire episode around a certain intervention or certain disease state at the moment, that you're able to show savings by enacting certain quality or other measures that are to increase efficiency, very much in line with what you hear that the current administration is driving for. So it started a few years ago. We're now we're finishing up performance year 4, but the impact is 2 years delayed. So we're seeing the results of performance year 2 this year, effectively it's still a complex process, but a lot more clear to those in their individual specialties about a specific uh, uh, interaction or bundle or procedure triggering, a typical kind of global time frame. And here's all the different episodes. We've now partnered with this well-established grouper of episodes called PACES, where if one of our specialties wants to bring forward one of these episodes as an opportunity to show savings, there's a way for the physicians to share in those savings. So it's essentially a shared savings model around an episode of care. And, what started off as really 3 specialties with, I think, 4 different episodes has expanded just in a very short time to include all of these different specialties. And some of them we're actually have the ability to develop our own in the state. And Gene can probably speak to a couple that we've developed using some of our MedChi members to be champions within their specialty to develop a unique episode that hadn't been able to be executed before.
And to that point, Dr. Lowentritt, we actually, Dr. Pines, who's an ER doctor, is a member of MedChi, part of USACS, developed a standalone ER episode a couple of years ago that's up and running. Dr. Grunner developed an MSK episode that really benefits actually physical therapists. He's a MedChi member and helped us do that. But we've also had some active physicians help us develop the PACES episodes out. So Dr. Roca, for example, worked with us to develop 2 psychiatry, a behavioral health, and a depression episode, and develop out the details around the PACES. So there's a lot of opportunity to either develop an episode directly, from scratch, like Dr. Grunner or Dr. Pines did, or to do it with and through PACES, because PACES is also expanding. So it's really now any proceduralist and primary care can participate. Any physician can participate. The question is, are there triggering episodes that make sense? But it's a really great opportunity. And one of the big benefits of it is you get the advanced payment bonus. If Congress funds it, you get the modifier adjustment, and you get to avoid filing MIPS. So there's a lot of benefit to physicians to participating on top of this shared savings. And this is all allowed as a result of the Medicare waiver. It's language that allows this to occur.
Yeah, and what that also means is that it's partially funded by that $4 billion, right? So the thing that we should say is that the federal government is not pulling out 100% of the support, but they're not committed to keeping it going under the same agreement that it's been, right? And it's going to be a significantly less amount, but that's some of the questions I think we have to yet to see is like, how are we going to see things phased in for some of those reductions over time? Where is there going to still be some degree of federal support? And what will we have to be maybe trying to get done at the state level?
Did you want me to go right into primary care, Dr. Wargotz?
Well, let me ask Dr. Lowentritt a question that comes up on occasion. So those are the programs, the EQIP program, and then Mr. Ransom will elaborate on the primary care programs. Those are direct impact on physician. There are other that are a little more nebulous, but they also result in direct impacts, potentially, unfortunately, potentially negative impacts on patients, on physician practices in the hospital with procedures, particularly surgeons and specialist surgeons such as neurosurgeons and others, where payments to the hospital, if they're changed dramatically, might result in tightening of budgets, capital budgets, and equipment budgets for equipment, and hence impact patient care in the hospital, what procedures are available, and how the physicians practice. Can you address a little of that, Dr. Lowentritt?
Yeah, listen, I think that was a big part of the complaints that we were hearing with the model as it exists now, is that hospitals were effectively controlling volume by restricting technology so that they wouldn't have doctors looking to do cases at their hospital. And by doing that, they wouldn't have the cost of doing those procedures. And they essentially, they weren't actively transferring patients, but they effectively were causing it that they were a less desirable place for certain specialties to work. And I 100% believe that was happening, and that was, either a conscious or unconscious part of the way that hospitals were developing their approach to maintaining their level of profitability, to preserve their administration under a global budget. That same risk now, of course, happens when you have truly reduced potentially, the future where you may not be getting that level of subsidy, and you'll be more towards some sort of other measure for value, et cetera. I do think, though, that network adequacy was a core part of what, not just network adequacy, but essentially specialty access adequacy to be eligible for these levels of support was a big part of what we were pushing for, and that hospitals had to maintain their ability to care for patients. For those that don't know, each hospital got their own global budget. So even if they were part of a big network of hospitals, it was never looked at the sort of system level. It was always evaluated at the hospital level. So, when you see patients shifting between different hospitals, it wasn't like it was being tracked by the HSCRC easily, that it was like staying within a system or even leaving a system. So I do think that any future iteration of how we're watching this is going to have to include some of that visibility. And I think issues like technology adequacy is also a big part of it.
Thank you very much. And of course, MedChi will keep an eye on that. We want to hear from you, the physicians out there in the community practicing in the hospitals, performing procedures, whether you're running into any roadblocks in this area of necessary technology to serve your patients. So you'll please keep us informed as AHEAD moves forward. Mr. Ransom, if you could kindly give us an overview and some specifics on how the primary care programs are faring under the new agreement, anticipated to fare under the new agreement.
Yeah, so it's interesting. When I first started as CEO of MedChi in 2009, we were very, very much not engaged on the HSCRC stuff. We had a rep on the commission, but we, kind of followed it. But in the last 15 years, we've really picked up our engagement. We have a large amount of staff and energy and physicians involved, and we have Dr. Lowentritt's committee now. But one of the things we did very early on, once we began that engagement with the HSCRC, was we worked very hard back, and I want to say it was 2018, 2019 maybe, to get language in the Medicare waiver at that time, in that total cost of care agreement, that created the Maryland Primary Care Program. The Maryland Primary Care Program has been in place for 6 years now. I guess they'll be going into 7th year next year. It is the largest per capita advanced payment primary care program in the country. There are literally 3/4 of adult primary care doctors are in it. It has been incredibly successful from an engagement and alignment point of view for physicians. The problem is that some have argued the savings haven't been there on the cost side, and that's put pressure on it. And there's been pressure from CMMI staff for several years and others to kind of say, hey, we need to get rid of this. And then also CMMI has said, we'd like you to do, national programs instead. So there's been this tension between the incredible success of MDPCP and what's going to happen. And you see that in both the agreement that was signed with the Biden administration and the new one we have now as amended, the Biden agreement as amended by the Trump administration. The Maryland Primary Care Program right now stays until 28, and there's a study, and then it looks like it's scheduled to go away. But we do have the ability to keep it if we can fight to do it. So this remains a priority for MedChi. Secondly, they have launched a new primary care ahead program, which doctors can sign up for. And we're hoping, and they have the ability to do open enrollment for MDPCP going forward. It's been closed out by CMMI for several years now. So hopefully next summer they'll have open enrollment for both Primary Care Ahead, which is a Medicare program. You cannot be in both MDPCP, the Maryland Primary Care Program, Medicare, and Primary Care Ahead at the same time. MDPCP has larger care management payments to physicians than Primary Care Ahead. The value prop is a little different on the two, but the dollar amount is clearly lower on the Primary Care Ahead program. The other new feature that has moved forward as a result of the AHEAD process is a new Medicaid primary care program, which has been launched, and we have a handful of physicians who are in it, and that will be expanding as time goes on. So those are the big primary care programs that are there. Here are the big concerns that we have. The Maryland primary care program possibly going away. Honestly, our preference, the MedChi preference, the clear position of the Looking Ahead Committee is we want to keep it. It's been successful. We have a lot of engagement. Doctors like it. We want to keep it and expand it. The federal government seems to be pushing hard for primary care ahead. We also have concerns about the primary care ahead payment methodology. It needs to be more robust. And then our third concern is really the Medicaid programs. We're concerned that some of the matching funds were cut by HR 1 recently and worried about funding. The issue is, and this question gets asked at the regular meetings. In fact, I asked it again this week at the regular touch base I have with the HSCRC director, as for my role as being on the strategic planning committee, is how, given the investment targets that are clearly in the agreement that both CMMI and the state have agreed to, are we going to make sure that we fulfill that promise with the way the programs are structured? And I'm told repeatedly, yes, that's a legitimate concern, and we don't have a good answer. So this is something that we will be working on. We're going to continue to work on. But I also think it's something we should step back and be very proud of, because the Maryland Primary Care Program is really impressive.
Very good. Well, I'll tell you, we will, as reiterate what Mr. Ransom said, we will continue to press for an answer on that and try to secure the funding. Anything to add, Mr. Ransom?
Nope.
Okay, very good. Well, let me just say, let me ask you this, Mr. Ransom, and follow up to your discussion of primary care programs. So we have the EQIP program, we have the MDPCP for now, at least, we have ACOs. Can you participate if your practice meets the criteria to participate, let's say in all three? Can you participate in all three, or two, or are you limited to just one?
No, in fact, if you're in MDPCP, we strongly urge you to participate in EQIP, because MDPCP is only an advanced payment model for Track 3. In Track 2, it's not, so you can get the MIPS benefit by being in EQIP. But you're allowed to be in EQIP, MDPCP, and an ACO. And actually, we have practices that are in all three, so that's not a problem. You know, one of the practical suggestions I would make, Dr. Wargotz, to any doctor where these care redesign programs are kind of new to them, or maybe they want to make sure they're doing everything right. MedChi has a Center for Value-Based Care, and they can reach out and talk to me or Olivia Simon or Andrea Mullen, and we can actually tell them and do an assessment and let them know what's available. One of the other exciting things that you brought up to me earlier in the week is the new access program, which it looks like, the way the initial language has come out from CMS, that you'll also be able to participate in that as well as the other programs too. So there's a lot of overlap that you can have with regards to these programs, and there are benefits in strategically aligning them up to maximize the benefit of each program and the revenue from each program.
Thank you. Well, we have about 4 minutes left, so let's use every second we have. I would like Dr. Lowentritt and Mr. Ransom to be able to give a brief minute or two summation at the end of their thoughts as we move forward. But before we get there, I would like to, number one, say that the access program by Medicare is a voluntary program. The enrollment begins in early January, and the first reporting will be in July, this coming July, and we will do more with that. You'll hear from us about that to help clarify and educate on that program that was rolled out just last week. I have one follow-up question that either or both of you can respond to. So we have pretty poor, or I'll say dismal, ER wait times in most of Maryland, some of the worst in the country, I would suggest. And I'm wondering how if you can explain to our audience and to me how the AHEAD model might affect or not affect at all potentially ER wait times, and how it might help with the shortage of primary care in the state of Maryland, which I'll be very interested in, along with everyone else, to hear about. So it's the ER wait times and the crises we have in primary care serving our public in the state of Maryland.
I'll go first.
Yeah.
I think what's important to realize is that, and this is the craziness of the way that the waiver is set up, right? That the only thing that the waiver historically and really going forward has even though it was total cost of care, the budgets were set off of facility-based care for what was considered regulated space, or essentially inpatient care is what it was supposed to be, or anything happening on the campus of the hospital, except for ERs, which were always exempt. ERs are not considered inpatient, they're not considered regulated space. So anything that happened while the patient was in an ER was able to be paid on a fee-for-service basis outside of the global budget. Just like when they buy a physician practice somewhere, anything happening in that physician practice is not regulated space. So you could argue, and a lot of us have, that there was no incentive for hospitals to get patients through the ER into the hospital, because the second they become an inpatient, everything that's done for them actually gets deducted out of their global budget, whereas they can bill fee for service for anything happening into the ER. So one of those examples of, you follow the incentives and you can kind of understand why this happens. Now, they've been shamed a good bit on it, and I think that's the only way really to get through quickly, is to continue shame. The new system may have different incentives, which I hope would put people more in line with the way the rest of the world works. But I don't think it answers the question. I mean, I think this is the real challenge of our times, right? As far as the programs that we've put in place have been to try to encourage more investment in primary care, which means more people coming into primary care. But it's not clear yet how, and maybe the access program and others will help replace it, but it's not clear exactly how the new model is going to fix that problem, right?
Thank you, Dr. Lowentritt.
Yeah.
Thank you very much. And Mr. Ransom, you want to do the key takeaways and anything you might want to add? Thank you, Dr.
Yeah, and I
Lowentritt.
saw Dr. Walsh's question about ER wait times. I do just want to say one thing, and I get in trouble sometimes with my friends at the state when I say this. In a private market, things move quickly, right? So when there's a problem like large ER wait times, the private sector moves in and fixes it because they make more money to do it. This system doesn't really have that feature. The HSCRC, the commission, has to take an action to make a change. So a few years ago, we had bad readmissions. The HSCRC put rules and regulations and penalties in place, and they got adjusted. And that's part of the problem with the ER wait time issue, is that the commission has just put a bunch of rules in place. There's a study that just came out on the ER wait times. Those changes are starting to make a difference, but it moves a little slower. There are other benefits from that. Obviously, we have rural hospitals that wouldn't be open. We have other things that happen. And Dr. Lowentritt talked about some of the other issues with the system, and we can talk about them ad nauseum.
Thank you, gentlemen. Well, why don't we sum it up, each of you, a minute or two?
Yeah, so essentially, just to sum it up, we've had rate setting in some form or another since 1977. We're going to have that for another 2 years. In 2 years, there's going to be a big change with the split rates. The global budgets will start to be scheduled and controlled by CMMI for Medicare. The other budgets will be done by the HSCRC. How exactly is that going to work? That's the $4 billion question. The MDPCP is a top priority for MedChi to protect and keep. It is scheduled to possibly end in 28. We need to get open enrollment back, and we need to keep it in place. MedChi CRISP and the HSCRC manage EQIP. Great program. You need to reach out to us and talk to us, and we're willing to help you with that. The term sheet has been signed, and we at least will have some stability in Maryland for a couple years. Dr. Lowentritt?
Yeah, I mean, listen, I think there's opportunity for us to continue to engage. I do think that there will be roles for our friends in Annapolis to weigh in, not necessarily directly on the terms of these deals, but we need things to help make sure that our patients and our doctors remain the focus of any overall improvement, and that doctors can continue to practice in the setting that they want to, that we don't have an assumption that whatever is going to change, to make the hospitals, whole, will somehow just drag the paid doctors along with it. So I think that there's a lot that we can continue to work on, and will continue to work on. We just need to remain ever vigilant and stay really engaged.
I want to thank our two experts, Dr. Lowentritt and Mr. Ransom, for their time today and expertise. And unfortunately, we don't have time for questions today, but what I would encourage you to do is email myself or Dr. Lowentritt or Mr. Ransom with any questions, follow-up questions or concerns you have about the AHEAD program, general, or maybe they're specific to your practice or your interest, and any comments you have about today's webinar. We really thank you for joining us. It's been very exciting for me, and I really appreciate everyone's time. Stay safe and have a fantastic holiday season, and we look forward to hearing from you and working with you. Take care.